Hello, everyone. We are live in our NCLEX Hour in Review today. And so for the newcomers, we are currently on the 16th day of our 90-day free NCLEX review series. And we tackle into different nursing topics and offering rationales for 2000 NCLEX questions. So make sure to tell your friends who are preparing for the NCLEX about our free review classes. And make sure you subscribe and turn on notifications to stay updated with our latest content. Now, for more information, please refer to the description box below. And we do appreciate your feedback, so don't hesitate to share your thoughts or questions in the comments section for further clarification on any topics discussed. Now, you can tell us also where you're coming from, which country or state, so you can add that in our chat box while we are doing this session. Now, StancoastNCLEX.com is also going to offer us the review program through our website, www.stancoastnclexcoaching.com. And the program offers engaging lectures and also a wealth of over 3,000 NCLEX style questions to help you prepare thoroughly. So for a quick review, we provide an audiobook and also a concise bullet book to streamline your study sessions in order for you to also engage with our 10-hour animated video course and take advantage of 100 hours of preparation time. And you can also access our on-demand video library and practice with mock exams and also to boost your confidence. So this is something that you can access for 6 months, including over 200 next-gen NCLEX questions. So you'll have everything you need to succeed. So you can do this also to do it on your own pace, wherever you are, and make sure that you subscribe to us and also enroll in our program so we can support you in your NCLEX preparation journey. Now, guys, we are going to talk about the topic today, which is all about the ARDS, or the Acute Respiratory Distress Syndrome. And for those who are already in the room right now, we have Mandeep Kaur, welcome to the class. And also for those who are in the classroom right now, welcome back. So guys, let's get started with our discussion. And let's define first what ARDS is. I'll just call it ARDS to make it short. So this condition is just like when both lungs throw a big angry tantrum. And so they can become swollen and also inflamed because of the too much action from the certain types of white blood cells called the neutrophils, right? And usually it happens very quickly within about a week of something else causing the trouble, like an infection or let's say an injury. Now, when the medical provider takes a look into the chest x-ray or maybe CT scans, they're going to see these cloudy patches all over the lungs, and it's like looking at a cloudy sky, but in your lungs instead. Now, what's going to happen here is that the lungs get filled with fluid, making it super hard to catch a breath. So we call them the infiltrates, right? And there's one thing though, it's not because the heart is malfunctioning. Nope, the heart is just doing fine right now, but the fluid buildup is all about the lungs being unhappy, all right? So we'll talk about the abnormal partial pressure of oxygen and also the FiO2. So basically, this is used to assess the severity of the acute respiratory distress syndrome, or the ARDS. And here's the simplest explanation that I can give you. So basically, the PaO2, or the partial oxygen pressure here, it is the amount of the oxygen in the blood, all right? Whereas the FiO2 is the amount of oxygen a person is breathing in. So therefore, the PaO2 or the FiO2 ratio compares these two values to see how well oxygen is getting from the lungs into the blood. So we have here the different abnormal ratios that can be tested in this patient with the ARDS. Okay, so we have here the value of 200 to 300. That's the ratio right there. So what does it mean? It simply indicates that the person now has mild ARDS and the lungs are slightly impaired in getting the oxygen into the blood. Whereas when there is 100 to 200, it indicates that there is now moderate acute respiratory distress syndrome, and then the lungs are moderately impaired in getting the oxygen into the blood. Now we also have this ratio wherein it says about less than 100, where it indicates that the person has severe ARDS and the lungs are severely impaired in getting the oxygen into the blood. So simply put here, the lower the partial pressure of the oxygen and also the FiO2 ratio, the more severe the ARDS and the more difficult it is for the lungs to have it in transferring the oxygen into the blood. So I hope that you're able to understand the concept about the FiO2 and the partial pressure of the oxygen, especially in this person with the different levels of severity in ARDS. Now, this time we're going to talk about the phases of the ARDS, because this problem actually can progress into 3 distinct phases. So we do have here our exudative phase, followed by the proliferative phase, and also the fibrotic phase. And we're going to talk first about the exudative phase, which is also known as the acute phase. So this is something that can start very abruptly, and this is going to happen after an injury, usually about the first 7 to 10 days. Okay, so what's going to happen here? There is going to be an inflammation, and also because of the damage to the barrier between the tiny air sacs or the alveoli and also the blood vessels. So what's really happening here? Well, the barrier gets all messed up, and because of the inflammation and also the action of the certain white blood cells, the barrier will going to start to leak, and this will now let the fluid with lots of protein in it to go into the air sacs, into the alveoli, making them to swell up. Okay, so this is basically what we call as the alveolar edema. Plus, this will cause trouble with the substance we call the surfactant, as we know that surfactant is something that can help keep the air sacs open. However, there is now a dysfunction with that substance, wherein there's no longer availability, or it actually will cause problem with its function. It's no longer able to cause that normal function of the alveoli to inflate and also to deflate in a normal respiration. So it doesn't allow that anymore. Okay, now, so how does the person manifest when this exudative phase comes up? How does this happen? Well, the person here will have a sudden big problem. They're going to feel that they're not getting enough oxygen. There is air hunger. And so when the person will have a chest x-ray, they're going to have the cloudy spots in both lungs. Like I've said, it's going to be bilateral, and they're going to end up with a hard time breathing. All right. Now let's move on into the proliferative phase. So what is this proliferative phase? This is basically going to happen from day 7 to around day 21. So that is about a week to, let's say, 3 weeks. So this is quite kind of a lengthy process, guys. So what is this proliferative phase? So after the first chaos has occurred, okay, we have that exudative phase. That's the chaotic phase. So after that has been completed, then things start to calm down a little bit. So what's going to happen here? There will be now some reabsorption of those fluid from the air sac. They're going to be soaked back up, and some cells in the lungs will start to grow and repair the damage. So that's why it's called the proliferation. And however, there is also what we call as the fibroblast activity. Now, what's going to happen here? There will be an improvement in the oxygen levels in your patient, and the lungs will become a bit more flexible, and they will have some, even though the person will still have some struggle to get enough the oxygen and might need some help with their breathing, but overall there will be some improvement in some cases, but not all. Okay, so basically what we refer to the proliferative phases, this is actually what we call as an attempt of the body to heal what has been damaged inside the lungs. Okay, so this is the body's attempt to actually try to repair all the damages in the alveoli. However, though, if the repair is failing or it doesn't work, then the person will go into the third phase we call as the fibrotic phase. Okay, and so this is going to occur more than 3 weeks. Okay, and this is actually going to cause a little bit more problems here. There will be some extensive fibrosis. The lungs will start to change in a more permanent way. So when it gets fibrotic, then things get more permanent here. There will be a lack of elasticity of the lung tissues. They will become stiffer and they're going to be filled with scar tissue. So it's not really that kind of a functional lung tissue like it should be. So it will cause the person to really have some hard time breathing, and this will require the person to need some long-term oxygen use at home because their levels will be on the low side. So this is what we call as the honeycombing. This is going to be the permanent defect or the restructuring of the alveoli, which are very stiff, fibrotic type of the lung tissue. So in simple terms here, guys, the person with a fibrotic face, actually, they're gonna have a very rough ride around this time. They're gonna have more of the permanent damage, and so again, they're gonna need some lot of support in order for them to survive. Okay, so to recap the different three phases here, the exudative, the proliferative, and also the fibrotic phase. Basically, the person will go into the stages, right? Wherein the first stage will be quite mizzy, okay? Wherein the alveoli will have a swollen start, then it goes into the next phase, which is actually the attempt of the body to heal the tissues, especially the alveoli. However, if there is no success in the healing process, then it goes into the third phase we call as the fibrotic phase. And this is going to be a much more of a permanent, long-lasting changes. Okay, so again, there will be widespread fibrosis in the lung fields. Now this time, guys, we'll take a look much deeper into the alveoli because this is where really the main action is going to occur. Okay, so I hope that you're able to capture the concepts, the preliminary concept that we have. Welcome into the classroom, all things home. Hello. We're gonna go into the alveoli and also the capillary. So I hope that you can clearly see that image. So basically, we're gonna have to talk about what will happen here during the event, especially in the exudative phase. So with the ARDS, we know already that there is what we call a severe inflammation and damage that will be caused here. And I'm going to try my best to really simplify things in explaining to you how the changes can occur. All right. So basically here, when there is an insult, it could be caused by so many factors. It could be an infection, pneumonia, or it could be drug toxicity, or maybe inhalation of smoke, or maybe near drowning kind of event. This can cause direct or could be an indirect injury into the lung tissue we call the alveoli. Okay, so when that happens, there will be now the release of what we call as the macrophages, right here, the neutrophils. So actually you're seeing in the picture right now a cross-sectional image of partly basically the first half here is the normal lung, right? In order for you to have a good comparison of what it looks like in a person's alveolus with ARDS compared to a normal or a healthy alveolus. Okay, so when that injury occurs, of course, I'm talking about the alveoli, right? This is going to cause the release of the macrophages and also the neutrophils. These are the soldiers, all right? That is going to be released by the body because they are known to be the innate protectors, all right? They are going to protect the body from any invading microorganisms, or if there is direct injury to the lung tissue, they will congregate into that area. That is their job, all right? However, though, their release, their effect can become so catastrophic, all right? They are going to ruin the alveoli when they're going to do a lot of stuff. Okay, so what is really going on here when these neutrophils and the macrophages? Well, they're going to have to cause the release of, let's say, the chemicals, the cytokines, okay? So the cytokines, example here, the interleukin B or the interleukin 1B, or also the tumor necrosis factor. Where are you? There, here we go. So these are the chemicals that will be released after the neutrophils will congregate into the alveolus. And they're going to signal that there will be more immune cells to come to the area. And again, the reason that they're there, they're trying to defend the body from the invading insult. However, again, they can cause damage. So with the neutrophils specifically, these cells or these white type of blood cells will actually release the enzymes, and they are toxic substances and can release those oxygen-free radicals that are intended to fight off the infection. But again, they can cause damage to the alveoli. All right. So one of those enzymes released is the acid protease, which is basically right here. Okay. And the neutral protease. So these enzymes will break down the proteins. And I'm talking about the proteins in the lung tissue, which is basically the alveoli. All right. So when this happens, when they are released, those proteases, these are going to damage the protein in the lung tissue, and this will now become inflamed right here. So comparing to the alveoli, in a healthy alveoli or alveolus, it's not thick, it's not inflamed. However, though, when there is presence of the acid protease and the neutral protease, it can cause inflammation. It will thicken that layer. Okay, so when this happens, this will now lead into what we call as the increased vascular permeability right here. Okay, so it will now cause the blood vessels to become more leaky, and this will allow more fluid to seep into the alveoli coming from the bloodstream, the capillary. So it will cross that barrier. Now, there's also going to be formation of the hyaline membranes. All right, so what is that? This is going to form a thick layer inside the alveoli, which is basically this one right here. This is the hyaline membrane that will start to build up inside the alveoli, and this will make it harder for the oxygen to pass through. Okay, so when the person inhales oxygen, it cannot go through the thick layer of the hyaline that has been built of the inflammatory process. So it will not be able to cross and get diffused into the capillary. Nothing of that can happen. All right. So what's going to lead into after that happens? Of course, you will expect that the person will end up with hypoxemia, right? Because it cannot go through that thick layer of hyaline. Now, with that, there is also going to be a buildup of fluid and also some more inflammation. And also, the enzymes will fill the alveoli. It will be so chaotic here. And it will become, it will allow the alveoli to become more stiff, and it's not going to be able to expand. I've said earlier about the problem in the surfactant, right? That it can cause a dysfunction in the surfactant action. So the lungs will become, or the alveoli will become stiff. It doesn't perform that lung recoil anymore. And again, it will not be able to allow the oxygen to cross from the alveolar lining into the capillary. So it is expected right now that there is going to be an impairment of the gas exchange. So the CO2 that's supposed to be um, to be carried back into the alveolus when you exhale, it cannot get that part. It will not be able to effectively transfer the CO2 because, again, this thick hyaline is going to obstruct the exchange of the gases. All right, that's why there will be an increase in the partial pressure of the carbon dioxide. That is going to be elevated. However, the partial pressure of the oxygen will go down. This is going to happen as we speak. All right. Increase carbon dioxide level in the bloodstream, and there will be a decrease in the oxygen level in the bloodstream as well. All right. So I hope that you're able to understand now in clear the mechanism of the acute respiratory distress syndrome. This is basically going to happen most in the alveoli, but we'll tackle a little bit more about its systemic effects, okay? But we're not done here yet in this picture. So with the continuous inflammation, remember that it will take about good 1 to 7 days, right? That's quite lengthy, guys. And of course, if the person is not really gonna be able to successfully repair the damages that has done to it, let's say in the proliferative phase, with that chronic inflammation, increasing enzymatic activity caused by the protease, and also the lack of oxygen, it will cause the lining of the alveoli to die. All right, I'm not kidding. It will cause it to be ischemic, it will become necrotic, and this will now be converted into a fibrotic lung tissue. Okay, scar tissue. Again, a scar tissue cannot do anything. It will not be able to assist in the exchange of gases. All right, so that's the sad part about it. But we're not done. We're gonna continue here with our discussion about the pathophysiology. So before we go ahead and do that, we'll have to identify the different risk factors. And of course, the first one here, and this is the most common risk factor, it is the sepsis, okay? And this can come in a form of, let's say, pneumonia, bacterial pneumonia, or it could be a viral pneumonia. It could be urosepsis, wherein there is an ascending infection in the urinary tract, maybe starting with a cystitis, and eventually it developed into a pyelonephritis. And of course, this will now spread into the bloodstream. So that can also cause the sepsis, which will lead into the ARDS. Now, for some people, their risk factor could be coming from a wound infection. It could be from a simple staphylococcal infection, and if the microorganism can cross the bloodstream, this can lead into systemic type of infection, which we call sepsis, and eventually will arrive into the lung tissue. All right, so what's going to happen? Same thing's going to happen here, guys. With that presence of infection, it will now trigger the immune system to release the chemicals, those cytokines, and will activate the neutrophils. So don't forget the neutrophils. This is what is really the main actor here. The release of the neutrophils really does a lot more chaos. Okay? All right. Now, with the anti-inflammatory, or the inflammatory rather, with the inflammatory mediators, the cytokines, they're going to have to travel to the lungs and again will cause damage into the alveolar capillary barrier. and this will now lead to increasing vascular permeability. It will allow the leakage of the fluid coming from the capillary. It will shift into the alveoli, and it will cause flooding. There will be consolidation inside the alveoli. Now, moving into another risk factor here is the aspiration of stomach contents. So what is going on here? Well, if in case the person will aspirate on any kind of stomach contents, including the gastric acid or maybe digestive enzymes, once they are going to be aspirated into the lungs, they're gonna get that inflammatory response. And again, the same kind of event will be triggered. It will cause some damage into the delicate lung tissue, and again, will lead into the inflammation. All right. So the same mechanism will occur. The inflammation will result into the damage of the air sacs and the small blood vessels, the capillaries. And again, there will be leaking of the air and also the fluid into the air sacs. And again, that characteristic pulmonary edema will also occur. So it's not gonna be, they're not gonna miss this one. Pulmonary edema is going to occur in this patient as well. Okay. Now, for those other risk factors like severe injuries, or could be caused by the bone fractures, or let's say the fracture of the femur or the pelvis, well, we know that the trauma can lead into systemic inflammatory response when there is fat emboli from the fractured long bones or the large bones. And these can also lodge into the pulmonary vasculature and will eventually result into the damage of the capillary, and also will lead into increasing permeability of the alveoli and also the capillary. And again, there will be inflammation and also damage into the lung tissue. Now, another is the pancreatitis. Okay, this is going to allow the release of the digestive enzymes and also the chemical mediators into the bloodstream, and which can also reach the lungs and will end up damaging the alveolar capillary barrier. And the same thing is going to happen. Same thing with the extensive transfusion, or let's say pancreatitis here. So especially for those patients that have this history here, TRALI, this is a rare condition wherein it can cause serious complication. So what is happening here is that there will be an immune response reaction that can occur here. This will now lead to the inflammation and also injury to the lungs. It will activate the neutrophils within the lungs. Again, some more damage to the alveoli, damage to the endothelial lining of the capillary, and also will increase the capillary permeability. Now, for those people that may have the near drowning event, the direct insult with the presence of the water going into the lung tissue, this can really disrupt the surfactant layer. So it has that direct effect into the lung tissue. Now let's move on into another factor here, which is drug overdose. This can also lead to ARDS. Let's say, for example, opioids, or let's say sedatives. This can really depress the respiratory function, and it can lead into hypoventilation, wherein the person's breathing will be much lower than 12 cycles per minute, and the person will end up with hypoxia. And some other drugs can also lead to a direct damage into the lung tissue. And again, the same process, there will be inflammation into the alveolar capillary barrier. And same thing, there will be pulmonary edema. And other risk factors like toxic inhalation, maybe because of some smoke, chemicals, it can cause direct damage into the lung tissue as well, and will trigger the inflammatory response. And I'm not going to mention the same mechanism, it will be repetitive. There's also increasing ICP. So why is this going to do, why it can contribute into the ARDS? Well, the elevation of the intracranial pressure can lead into neurogenic pulmonary edema. So in this type of condition, the sympathetic nervous system will actually respond to that elevation of the ICP. So it will trigger vasoconstriction and now will increase the capillary permeability of the lungs as well. So again, this will now lead into leaking from the blood vessels into the alveoli and will result in the pulmonary edema. Now, we also have some cases, let's say cardiopulmonary bypass, which is rare, but still it can also activate the release of the inflammatory pathways. Same thing's going to happen. Inflammation, direct mechanical injury into the lungs, and damage into the endothelial layer of the capillary, and also the alveoli will have much more of like a progressive inflammation until it gets necrotic. All right. So while we have already discussed all those risk factors, these are now going to lead to inflammation of the lung tissue. Okay. So don't forget about that. That is our primary first step. With that insult, this will now cause the inflammation because of the neutrophils, the macrophages, and also the cytokines. So when this happens, there will be now migration of the neutrophils into the alveoli. This is what we call the exudative phase. Again, it will take place during the first 7 days after the initial insult. All right. Now, talking about the release of the cytokines, the chemokines, the proteases that we talked about earlier, it will now exacerbate the damage to the lung tissue. But when we go further, this can now affect the surfactant function. Okay, now remember again about the function of the surfactant. It's basically that substance that will allow the lung to collapse and also inflate during the normal ventilation process, during the inhalation and expiration. So it can do that. However, with the impairment in the surfactant function, this can now cause some collapse, dead space. All right. So with that, when this thing happens, this will now lead into the alveolar collapse, or basically what we call as atelectasis. So the person will still breathe in air. However, because of that thickening, the inflammation of the lining in the alveoli, there will be no proper gas exchange, like I've shown you in that specific slide showing you the alveoli. So this will now lead into alveolar collapse. There is no exchange of gases there. There's no perfusion. There's no airflow. So when this happens, this will now lead into what we call as ventilation perfusion mismatch. Because of the collapse, there's going to be accumulation of fluid in the alveolus, and so many debris is going to cause the problem here. There's no perfusion, again, no crossing of the two gases. And when this happens, it can directly cause the partial pressure of the carbon dioxide to go up and the partial pressure of the oxygen to go down. Okay. So, hang on a sec. Yes, decreased partial pressure of the oxygen in the bloodstream, and also the pulse oximetry reading, the oxygen saturation. When you're looking into their pulse oximetry, it will be decreased, maybe in the 70s, 60s. So, yes, it's that bad. Now, the person will also have some increase in the partial pressure of the carbon dioxide because of the accumulation of the CO2 in the blood vessels, in the bloodstream. It's not able to cross into that alveolar barrier because of the thickening. And the patient will end up with tachycardia. Their breathing becomes so fast because of they're trying to compensate with the low oxygenation. So that is the body's normal response. Now, with the migration of the neutrophils here into the alveoli, well, what it can do, it can also lead into more neutrophils to infiltrate, and again, the release of the cytokines. Okay, so what happens here? It will now cause damage, direct damage into the epithelial cells, and will now lead into that VQ mismatch as well. All right, very easy. With the release of the cytokines and also the neutrophils, it has a direct effect, which is the pulmonary edema. And with that, the chest x-ray will show bilateral opacity. So you will have that whitish spots. Infiltrates will be shown into the chest x-ray or the CT scan. And because of the neutrophil migration, infiltration, and also with the release of the cytokines, this will now cause the deposition of the hyaline membranes in the alveoli. Remember about that thick layer that is going to grow in the lining of the alveoli. It will thicken, and that will cause the block that it will now prevent the crossing of the CO2 and the oxygen. So there will be no more diffusion. So when this happens, it can lead into impaired gas exchange, and eventually will do the same thing here. Elevation, the partial pressure of the carbon dioxide, decreased oxygen saturation, partial pressure of the oxygen will go down as well. There will be tachycardia, tachypnea. Yeah. Now, with the second phase of the ARDS, the body will try to repair the damage that has been done. And this is going to lead into the proliferative phase, right? I've said that earlier. When this happens, the body will attempt to lead into allowing the phagocytic cells to clear their residual debris inside the alveoli. So they're going to eat up all those debris. And when this happens, if it becomes successful, then there is now going to be improvement in the gas exchange if the person gets lucky, right? And if there is also a successful repair, there will be now some kind of like partial restoration of the epithelial cells in the alveoli. And when this happens, it can now show some improvement into the lung tissue. So it can be shown in the chest x-ray. Okay, so the opacities in the lung fields, the infiltrates will diminish. So that's something that can happen, right? For those who are lucky. However, for those people that are not fortunate or they're unfortunate, they're going to lead into the fibrotic phase. Okay? When this happens, there will be now increasing fibroblast activity, and this is actually going to lead to a much more excessive collagen deposition. Okay? This is the key word right here. Deposition of the collagen. All right. When this occurs, it can now cause the pulmonary hypertension. Because of the fibrotic tissue, it will now cause that pressure inside the lungs to go up. And it will lead into stiffening of the lung tissue. It will be less compliant. It will not really function compared to a normal lung tissue where it will recoil so easily. It's so fluid. But here, the alveoli are non-compliant. They are very difficult to inflate. That's why they're going to end up with the pulmonary hypertension. Now, the person will also have the pulmonary fibrosis, right? Wherein this is going to be irreversible, and this will also develop into much more problems. There will be less oxygenation, less functional alveoli to cause the diffusion of gases, and of course the person will require lifelong oxygen supplementation. So they're going to end up with chronic use of oxygen at home. All right, so I hope that you're able to capture really the mechanics in the ARDS. So may I ask you, were you able to understand the process? May I see your comment? Okay, I hope so. So I hope that you were able to capture all that. There's so many things going on, but yeah, That would really help you to recall the concepts rather than just memorizing the words, right? So it's better to really understand the pathophysiology in order that you can understand the different assessment findings and what to do with that abnormal assessment finding. That's the key, guys. All right, so let's talk about the diagnostics. So what are the tests that will be ordered by the medical provider to identify this problem? ARDS. Well, of course, we've seen this already, the chest x-ray. So it will now cause the, it will show us the widespread bilateral lung infiltrates. Why? There is widespread lung infiltrates. Remember about the pulmonary edema and also the release of those debris? Yeah, that will now show up as infiltrates in the x-ray. Pulmonary edema and also the presence of those debris, consolidation of the fluids inside the alveoli. Now, let's talk about the consolidation or the pulmonary edema that is involved here. This is gonna affect the patient's oxygenation. They will become hypoxemic. Again, there is no proper crossing of or diffusion of the gases, the CO2 and the oxygen. And here, the person will probably respond to, let's say, a treatment when there is injection of the loop diuretic like Lasix. So they're going to have some improvement if we administer this medication to get rid of the extra fluids that are inside the alveoli, okay? But again, this is not caused by the heart. This is not because there is a malfunction of the heart. It is because of the inflammatory responses that has happened inside the alveoli and also the capillary. Now, another test that is very important for us to know is the arterial blood gas. So what is expected here, guys? Well, there is going to be hypoxemia. The oxygen level can go down as low as less than 60%. That is really low, all right? Or 60 mmHg rather. Now, we are also going to expect that the patient will go into alkalosis, but here's the condition: initial. During the early phase, in the exudative phase, the person will go into respiratory alkalosis because of the air hunger. The body will try to compensate by making the breathing so fast. The person will be tachypnic. Maybe it can go as high as 40 cycles per minute. So the person here, during the early stages, will be losing way too much carbon dioxide. That's why there will be alkalosis or respiratory alkalosis. And this is going to be seen in the ABG. The CO2 will be less than 40. All right. However, during the late stage of the ARDS, this will now convert into respiratory acidosis. That is because of the accumulation of the CO2 in the bloodstream. All right. There is now limitation of the diffusion. It cannot escape. It's going to be in the bloodstream. Now, especially when the metabolic acidosis, this is expected, especially in a case of sepsis, right? Yeah, anaerobic metabolism, lactic acidosis can occur in sepsis. And this might occur with or without some respiratory compensation. So keep that in mind, guys, that the metabolic acidosis, especially if a person has the ARDS caused by sepsis, the imbalance here, the acid-base imbalance might just go ahead. Hey, I'm just gonna go by metabolic acidosis now. I'm not really gonna need the lungs to compensate. All right, so that's how bad this is gonna become. All right, now for the other diagnostic test, we'll see that there will be the use of the pulmonary artery catheter. So what is the significance of this diagnostic test? This is going to measure the pulmonary capillary wedge pressure, which is basically going to show us the pressure in the left side of the heart, the left ventricle. And this is going to differentiate the acute respiratory distress syndrome from the cardiogenic pulmonary edema. And so here, guys, This will show low PCWP, or the pulmonary capillary wedge pressure, which is basically going to be less than 18 mmHg if it is ARDS. Okay? However, the PCWP will be elevated, which is going to be greater than 18 mmHg, if the respiratory distress was caused by the cardiac or cardiopulmonary type of edema. All right, so I just want you to distinguish this. The PCWP will be low if it is a real ARDS. However, if the respiratory distress was caused by a pulmonary cardiogenic type of pulmonary edema, then the PCWP will be have a higher reading. It will be greater than 18. So that would really give us an idea, hey, this is not something about ARDS. This is specific to cardiogenic type of pulmonary edema. So I hope that you're able to get that one. Now, we're also going to talk about the bronchoscopy. So this is an invasive diagnostic tool, of course, with the use of the fiber optic tube, with accompanied by the bronchoalveolar lavage. So there will be bronchial washings in order to clear those debris that have been lodged into the alveolar tissue. And so this is going to be indicated for those acutely ill patients with suspected type of, like, let's say maybe they have an ongoing infection. So the bronchoscopy with the bronchoalveolar lavage will work for them. And also the medical provider who's doing the test will also be able to collect the fluid, and they can use that fluid to be analyzed in the form of a culture. Maybe they're gonna do some cell differentials in it, maybe cytology, and they can do some stains as well to see what kind of infection the patient is having. All right, so that is about the bronchoscopy. Now we're gonna move into the treatment right now. So what is going to be the treatment for this patient? Well, first things first, we're going to need to give oxygen therapy to the patient. And our goal here is to keep the saturation greater than 90%, at least 90%. But in more severe cases, the patient might need help with the use of the mechanical ventilator. They're going to end up being placed into the mechanical ventilator because of the gravity of the severity as well, the damage, the extensive damage that the inflammation has caused into the lung tissue. It's widespread. We're talking about both lungs here, guys. And so this can really cause lung collapse, hypoxemia, and so many other things that can complicate here. And so here, what we're going to need to know is about the PEEP. What is this PEEP? This is going to be one of those settings that we will be regulating as ordered. Also with the low tidal volumes for this patient with the mild to moderate to severe type of ARDS, and they're going to require some sedation and also paralysis with the use of the medication in order to help the ventilator to work better. Okay, so the patient here will require those medication in order that their lungs will be compliant to the setting in the ventilator. Okay, so that is the reason that we are going to give them the sedative medication and also those paralyzing agents in order that there will be compliance in their lungs while they are being intubated. Now, there's also a need for us to manage the fluid of the patient. So how are we going to do this? Well, this is going to be a difficult one. It's a balancing act. Why? Because we don't really want to administer way too much fluid. Why? Remember about the pulmonary edema that we talked about? So we're looking into the alveolus here. We have another alveolus, another alveolus. Remember about the consolidation, the edema inside the alveolus? Remember about that? And we're also talking about the capillary. That is congested with the blood, right? There is pulmonary hypertension. So we don't really want to add way too much fluid into this patient. So we're not going to expect a whole lot of the boluses of IV fluids here because we don't want to overload. We don't want to drown our patient with way too much fluid. So we have to make sure that we're only attaining at least low to normal intravascular volume. And this is going to be with the use of the CVP. Let me correct that. CVP. Yeah, I thought I put a CVP. Yeah. So fluid management. So that is CVP of 4 to 6 centimeters of water. Let me go back into that page. CVP. All right. That's all right. Okay, let's get moving here. Again, we don't want to overdo the fluid replacement because of the pulmonary edema. We don't want to drown the patient. And along with that, because of the hypotension, the low cardiac output, remember guys, there is poor exchange of gases, there is hypotension, the patient will need some support with a medication. And this is to keep the blood pressure much more stable, especially for those patients that may have sepsis. They're the most difficult to manage, okay? Balancing act really as far as giving the IV fluid, the use of vasopressors in order to at least maintain a much, I would say probably a much more stable hemodynamics for this patient, which is kind of be challenging to achieve. Now, also in the treatment of ARDS, we are going to have to address the underlying cause. Maybe if it's an infection, there we're going to have to expect some blood cultures first to be done in order to identify the infecting microorganism, and then we're going to have to treat that patient with the appropriate antibiotic and also corticosteroids. Yes, because it will also help in the inflammation. It will decrease the rate of the inflammatory process in the lung tissue. So the corticosteroids, like with the use of the methylprednisolone. All right. Now, diet or nutrition is also going to be a huge factor in the treatment, because if the person is not going to be getting the right nutrition, they're not going to heal, right? Our source of protein will be dependent on what they have taken in. So, but here, guys, we are going to consider more of the tube feedings rather than having a parenteral nutrition. Why? Because with the use of the parenteral nutrition, this is going to allow the possibility of some more infections, especially with the central line being in play. Yeah, there is a higher incidence in the development of infection with the use of a central line. So we want to avoid as much as possible any of those risks to occur in this patient. Even though the tube feedings can also have some risk, but they're not known to really cause a much more of like trouble compared to doing the central line type of parenteral nutrition. Okay. Now we're going to talk about this time the different complications of ARDS. Again, if the patient will end up with the fibrotic phase, well, remember about the irreversible damages. It can cause the permanent lung damage, and it will lead into scarring, scar tissues, I said. And this is what we refer to as the honeycomb lung. And so it will really leave a lasting mark on the lungs. It will cause scarring, that honeycomb appearance, and it's going to make the breathing much harder. It will not work properly. Now, another thing is that there is going to be that barotrauma. So what is this? This is something that can be caused by the mechanical ventilation itself. Even though we are treating the patient with the use of a mechanical ventilator, that modality can also cause some problems if we are not very careful when how we deliver the settings. or just spontaneously, it can really cause a complication. And so the person here will probably develop pneumothorax or maybe a pneumomediastinum. And so this is basically air leaking into the chest cavity. This is what we call as the pneumomediastinum, which is the air leaking into the chest cavity. And pneumothorax is no joke as well, right? This is that presence of the air in the pleural space. And when this is going to grow bigger, right, this can cause compression into the other lung tissue, or it can also compress the vena cava, which will lead into a decrease in the venous return. It can also decrease the cardiac output. It can decrease the blood pressure. So your patient will end up way so much more compromised. And when we're talking about the use of mechanical ventilator, that protective lining or the protection that we supposed to have, let's say like right now, I'm just talking right now, I have that protective lining that will cause those microorganisms that are trying to enter, they're going to protect the upper respiratory tract. So they will guard in order to keep those microorganisms away. All right. However, though, when there is that endotracheal tube, when the patient is placed on the mechanical ventilator, that barrier is no longer there. So that is why the patient is prone to develop what we call as VAP, ventilator associated pneumonia, VAP. Okay. So that is one complication of the ventilator use. Now, aside from that, well, I think this is quite related to the hospital-acquired pneumonia. This is what we are referring to as the VAP. Okay, that's the one. And also, if there is a poor practice in the hand hygiene among the healthcare workers, suctioning, or with the use of maybe contaminated suction, repeated use of the catheter, oh my gosh, that's pretty bad. That would introduce some more infection into the lungs. And also poor oral care. Guys, if you become ICU nurses, oral care is very important because of the presence of the normal bacteria, or let's say maybe because of the antibiotic therapy, there is now an overgrowth of those bacteria in the oral cavity. And so if we are not providing appropriate oral care to the patient while they are vented, this can now get introduced into the lower respiratory tract. They're going to end up with much more type of pneumonia. Yeah. And so another thing is that with the ventilator use, there's also going to be some infections associated with the use of the central lines. It could be with the central venous pressure device, or it could be the ART line, or the PCWP type of catheter, the catheter that we use for that measurement, urinary catheters, nasal tubes, anything can be a pathway for these microorganisms to go inside the body and the bloodstream as well. Now, the person will end up with a renal failure. Well, why? Because we are probably treating them with some antibiotics that are known to be nephrotoxics. Let's say vancomycin. Yeah, they can really cause that problem, guys. Or maybe sepsis. There is prolonged low blood pressure. And when this happens, there is low blood supply to the kidneys. And when it is extended, when the blood pressure is not stabilized immediately, this can lead to acute renal failure. And this is something that I mentioned in our discussion in the kidney concepts, right? Renal concepts. Sepsis can be one of those factors. Now we're going to talk about the ileus. What is this? Well, this is something that can happen especially in a patient that is bedridden in the ICU, and also with the stress ulcers. And of course, with decreased mobility of the patient, there will be decreased peristalsis. Yeah, this can complicate some more things. Development of stress ulcers in the stomach and the intestines. or the paralysis of the intestine itself. And if not treated right away, this can lead into perforation necrosis and can lead into peritonitis. Now, take note, guys, that the multi-organ failure can readily occur in this patient, which is really going to complicate more things. Okay, so this will affect the other organs, the liver, the kidneys, the brain, the spleen, everything pretty much. And so again, this will probably be the reason that the treatment will become much more of a palliative. Probably aggressive treatment will be halted because the body is no longer able to handle the treatment. There's just less chance for the body to recover. And so, yeah, probably the care of this patient will transition into probably a palliative. The patient probably, or the family will probably decide on having the patient become a DNR, or if there is already a pre-existing DNR, then all those other heroic measures will not be pushed through. Okay. Now, with the prolonged physical activity, this can also lead to muscle and nerve damage, as we know that with the muscle, less muscular activity, there will be atrophy, and also it's going to affect the nerve function. And this will really complicate things if there is no involvement in the early use of the physical therapy in the acute phases. This can do so many problems later on. Now let's talk about the nursing care. This is very interesting, my favorite. So what are we going to do here, guys? We're going to definitely, during the acute phase, we're going to have to observe, assess our patient for the physical signs that indicate that they have some difficulty breathing, the distress. So look for those early signs. Tachypnea, there is use of the neck muscles, the sternocleidomastoid muscles, and there's also tracheal tugging, okay? Or let's say sternal retractions. There will be flaring of the nostrils, and there will also be sweating, diaphoresis. And the patient around this time will report feelings of short of breath, or let's say they are trying to catch their breath and they just can't. And around this time, you really have to be quick in your assessment. Now you have to listen to their lung sounds as well. If you're gonna hear absent sounds, diminished breath sounds, that simply means that there is now what? Poor lung ventilation. There is no more exchange of gas, right? Like I've shown you earlier in that big alveolus with the edema going on, the thickening of the hyaline lining, there is no exchange of gas. So again, it will now cause lung collapse. All right. Now there's probably going to be some wheezing because of the presence of those exudates that are being trapped in the bronchioles. All right. This can cause bronchospasms as well. You will probably hear the patient with that really noisy bronchi. They're going to have the coarse crackles. And these are adventitious sounds that are really going to be the telltale sign that your patient is having the ARDS. Now, the next is we're going to have to assess the patient's level of consciousness and their tolerance for the increasing breathing effort. So here, we are going to see that our patient probably is getting more confused. They're going to be having drowsiness, maybe lethargy. They're going to have some rapid shallow breaths, and their movement, there's going to be abdominal movement during the inhalation and probably the use of accessory muscles. The intercostals will be retracting, and this is really a sign that they are struggling to maintain the sufficient ventilation. Okay, now we're also going to check for the signs of low oxygen, guys. So how are we going to do that? Well, simply with the use of that pulse oximetry, you can do that. Continuous pulse oximetry monitoring, and also review the results of the arterial blood gases. So here, what we're going to expect is now going to be an elevation of the partial pressure of the carbon dioxide and a drop in the partial pressure of the oxygen. And of course, there is going to be a drop in the pH, less than 7.3. That is acidotic. So at this point, this is really going to require the person to be on maybe a non-invasive type of ventilation, maybe a BiPAP or a CPAP, or maybe the more invasive type, which is the with the use of the mechanical ventilator. All right. Now let's go to, all right, here we go. Mechanical ventilation is indicated, especially if a person is acidotic. And we are going to assess the patient's vital capacity and also the respiratory rate. So what is this? We are going to compare with the thresholds for the mechanical ventilation. So make sure, guys, that the vital capacity for this patient, not that assessment, rather. The patient's vital capacity for this patient is going to be this one, less than 15 mLs per kilogram. Okay? And the respiratory rate will be greater than 30 breaths per minute. And they are going to have that negative inspiratory force, which is going to be less than 30 centimeter water. Okay? So think about these assessment findings in this patient with the ARDS. Look into the vital capacity. More often, they're going to be lower than 15, or respirations greater than 30 breaths per minute, and the negative inspiratory force, or known as the NIF, NIF, this is going to be less than 30. So guys, why are we talking about this? Well, the normal negative inspiratory force, which is what we call as the NIF, is typically greater than 60, negative 60. That is the normal value. And the unit of measure is centimeter water. Okay, that is the normal NIF. So in a normally functioned lung, we are expecting greater than that. Okay. However, if the person with the ARDS has, if the patient has ARDS, then their value will be less than 20, or even less than 30, or less than 20 cm water. And this is really going to tell us that there is what we call as respiratory muscle weakness. It's not now able to support the lung function. Respiratory muscle weakness. Remember that the respirations is actually going to be innervated by the diaphragm, right? Remember the thoracic nerves that we talked about the previous day, that with the poor function of the muscles, this is not going to be able to support in the inflation and also deflation of the lungs. No more. So it will really cause the person to have lung collapse, also respiratory arrest. So there is also going to be a persistent low oxygen level in this patient, guys. So let's get rid of these. There's way too many. And around this time, what we're going to talk here will be about the setting, or especially the assessment here. So this is very important. What are we going to do here? We are going to assess the patient's hemodynamic status. So what are we going to do here? We'll check the patient's blood pressure, the heart rate. We are going to catch any changes that could really signal that there is distress, respiratory distress. And we're also going to look into the pulmonary capillary wedge pressure right here, the PCWP, in order to monitor the ventricular filling and also to assess the mitral valve function. That's why we need to have this. And this is going to be, the patient that we are talking about right now is already in ICU. You cannot do this in med-surg. And so the patient will be monitored to these things, okay? Also the cardiac output. Why? Well, when there is a compromise in the ventilation perfusion, it can really cause a drop in the cardiac output and the blood pressure will go down. So there is now a compromise in the blood supply to the body organs. So remember about the cardiac output that we talk about? Normally it's about 5 to 6 liters per minute, but in such a case with ARDS, it's low. So the body is no longer able to perfuse oxygen to the body organs. All right. Now, we are going to talk about the PEEP, which is the positive and expiratory pressure. And this is a setting in the mechanical ventilator. So I just want you to get familiarized with this one because probably this will come out in the exam. We don't know. So I'd rather have you ready to identify these settings. So what is the PEEP again? This is going to be set in the mechanical ventilator in order for us to keep the air sacs in the lungs ventilated and open and to prevent the air sacs or the alveoli to collapse. Okay, so we have to put the PEEP setting in order to prevent that complication. All right, so what are we going to do here? The appropriate setting here, especially during the initial ventilator, when we are just initiating the patient into the mechanical vent, what we're going to do here is to program the assist control mode. And this is during the initial phase. Okay, so our setting here will be assist control mode. And this is going to be followed by the tidal volume of 6 mLs per kilogram according to the ideal body weight of the patient. So that is our reference. And also we are going to set the respiratory rate at least 25 cycles per minute. Okay. And after that, we're going to have to regulate the flow rate at least 60 liters per minute. And then the FiO2 at 1.0. And then our PEEP setting in the initial stage will be about 15 centimeter water. Okay, please take note of this. This is going to be our initial setup for the ventilator with the patient and ARDS. Okay, so with all those complex setup, we are going to have to also regulate the FiO2 once the oxygen saturation has come up greater than 90%. So after all these setting has been completed, and if there is some slight improvement in the oxygen saturation, at least 90% or greater than that, then we are going to adjust the FiO2. We are going to decrease that amount. Okay. And this is going to be, cause us to regulate the PEEP as well, decrease it to at least 2.5 centimeter water increments as tolerated. So slowly, little by little, we're going to have to adjust the PEEP, okay? As long as the patient can tolerate that one. And then also the respiratory rate is going to be increased up to 35 cycles per minute in order to achieve a pH of greater than 7.15, okay? Somewhat really complicated, guys, but I'm just giving you an idea of how the setting's gonna be during the initial stages. Now, we are going to be probably asked, or you're going to be asked in the NCLEX. This is the main thing here. What is your role as an RN when your patient is intubated and they are mechanically ventilated? We are going to monitor them for the possible complications, especially with the PEEP setting, okay? Why? It's because the PEEP setting, if we're not paying attention to that, it can cause these problems wherein it can lead into decrease venous blood return to the heart because of the increasing intrathoracic pressure. Because of the mechanical ventilation, we are increasing the intake of air. We are actually allowing the air to go into the alveoli in order to prevent the collapse. However, though, with that modality, you really have to pay attention here, because the blood pressure of the patient, the cardiac output of the patient will also go down as a result to that. This because of the increasing intrathoracic pressure of the patient. This will now compress the vena cava, which will result into a reduction in the venous return to the heart. So there is now a decrease in the preload. Less blood will be able to go inside the ventricles. Reduced preload. Now, another reason for that complication, it's because of the reduction in the preload. There's also going to be a reduced cardiac output. And when we know that there is cardiac output reduction, this can also impair the patient's blood pressure. It will also go down. All right. So that is why it's very important for us to really keep an eye into the setting. Make sure that you are monitoring the patient's responses hourly. You have to do that, guys. Make sure that look into the hemodynamics, look into the physical features of the patient while they are being vented, because things can get complicated pretty soon if we are not early capturing these things. All right, so I hope that you're able to understand about the role of monitoring the PEEP. Okay. Now we're going to talk this time the intervention. So again, oxygen therapy is the mainstay. We are going to establish that goal that the patient's partial pressure of the oxygen will be at least 60 mmHg, or at least an oxygen saturation of 90%. All right, that is our realistic goal. And we can also administer those needed medications prescribed. It could be in a form of a diuretic. Why? We have to administer diuretic, maybe because the patient has pulmonary edema, right? The consolidation of those fluids in the alveoli. So we're going to get rid of that extra fluid in the lungs. And with that diuretic, expect that the patient will be excreting way too much urine. So make sure that you are monitoring the urinary output as well. And of course, with a patient that is septic, maybe there is an ongoing infection going on, then we have to expect the administration of the antibiotics, or maybe some cardiac medications, and it's just going to be dependent on what kind of underlying condition that they have. And so here, we're also going to monitor the patient's fluid balance through looking into the intake and output, their daily weight, the measurement of the pulmonary capillary wedge pressure. This is very important, guys. So we will be able to tell that the patient probably is retaining fluids in their body, which is not good. Make sure that their eyes and nose are kind of like close to each other. There is not more in than the output. Also, we're going to have to prevent the occurrence of the hypoventilation and atelectasis. So how are we going to do that? We are going to promote the chest expansion, and also the with the use of the incentive spirometer. So when the patient is able to do that, let's say they are already recovering, they're probably not in ICU anymore, they're not vented, so they can start using the incentive spirometer. Or maybe the patient really has not gone into that severe form of ARDS, then they can still use the incentive spirometer. Also, we can administer the nebulization, or the respiratory therapist will be administering that. And make sure that the head of bed is elevated at least 30 degrees angle, but much more, we're going to make sure that it's about 90 degrees. And there's also an importance about frequent repositioning of our patient in order to prevent decubitus ulcers. And also, we can help the patient to get out of bed when they are stable. So that would be better as well when they are recovering. Now, around this time, guys, we have to monitor for the patient's alveolar ventilation adequacy. So this pertains to their oxygen levels, their saturation, the arterial blood gas, the respiratory rate, and the function, or the forced vital capacity. Okay, so what is this forced vital capacity? This is basically the total amount of air that a person can forcibly exhale from their lungs after taking the deepest breath. Okay, again, this is the forcible amount of air that the patient can exhale. All right, so what is the value of the FVC? Well, normally in males, the acceptable amount is around 4 to 4.8 liters, but for females, the acceptable level is around 3.1 liters. Okay, so anything lesser than these numbers, less than 4.8, less than 3.1, if they're not able to really forcibly expel that amount of air, then that's actually telling us that there is no longer there is now an impairment in the gas exchange of our patient. There is lung collapse. Okay. Now we're going to have to talk about comparing the monitored values of the patient with a mechanical ventilator. So we are going to report and also prepare for a possible non-invasive ventilation or maybe intubation if necessary. Now, at this point, we definitely need to maintain the patient's airway open. Keep a patent airway. And how are we going to achieve these, guys? How are we going to do that? Well, through pharmacologic management, what we can do is to administer the bronchodilators, the corticosteroids, in order to lessen the inflammatory process in the lung fields, to reduce that inflammation because of the presence of those neutrophils, those interleukins, the proteases, the TNF. If we are going to administer the corticosteroids early on, this will really slow down the process. It will halt the inflammatory process. So this is a good intervention that we can do for the patient. Also, we are going to promote the pursed lip breathing and also assist them with effective coughing exercise. Okay. However, though, if they're not going to be able to cough the secretions effectively because the secretions are so thick, very mucoid, we are going to assist them with the suctioning. Okay, so we can do nasotracheal suctioning in order to get rid of those secretions, right? Because if we're going to let those secretions spool inside the alveoli, it will just complicate things. It will worsen the hypoxemia. Okay, so we want to make sure that we are going to auscultate our patient, make sure that we are listening to their lung sounds. If they are very coarse, crackly, we definitely need to get rid of those gunk in their airways. Now, we are going to talk about the maintenance here, the patient education that we can do early on, even before the patient gets discharged to their home setting, or let's say the nursing home, or maybe the assisted living. As early as possible, we need to incorporate the teaching. All right. So probably you're going to be asking the NCLEX, how are you going to implement this education to your patient? Well, what we can do is to at least advise the patient to seek help, early help, in order for them to get medical or prompt medical attention. If in case they're going to have some form of upper respiratory tract infection, make sure that they notify their medical provider in order for them to get an early treatment before things get worse. Okay, especially with the pneumonia, bacterial pneumonia, with the COPD complicating, emphysema, bronchitis. Yeah, we talked about those the other day, right? Yes, this can really complicate things all the more, and make sure that they are going to be treated as early as possible to lessen the inflammatory process. Now, we're also going to educate our patient about their medication schedule, make sure that they understand about taking their medication on time in order to facilitate therapeutic levels of the antibiotic in their bloodstream. And also, if they have an order to take the corticosteroids to decrease the inflammation, then definitely let them know the reason behind that. Now, we are also going to teach the patient about the, especially if they're at risk, that they need to get their pneumonia and flu shots annually. This is really going to be applicable for those at-risk people, especially during the cold season, the flu season that starts around September, October. Yeah, definitely they need to get that coverage as well. If they did not have any adverse reaction in the past, then they can get benefit of the pneumonia and the flu vaccination as well. Now, also, we are going to recommend the use of both the PCV13 or the PPSV23, which are actually pneumonia vaccines for the adults greater than 65 years old, and also the PCV13 if needed. Okay, so these are the things that you need to include in their education, especially if they are at a higher risk. All right, well, guys, we'll have a little bit of a recap here. So, again, thinking about the ARDS, remember about the several factors. It could include infection in any form that can cause sepsis. It can trigger the inflammatory response, the release of the neutrophils, the cytokines that can cause that cascade, the release of the proteases, those enzymes that can lead into some more problems in the alveoli. And along with the other factors that could be causing indirect effect to the alveoli, remember about the same pattern. It can cause inflammation into the alveoli. It can cause pulmonary edema, thickening of that layer in the alveoli, which can prevent the exchange of CO2 and oxygen. And also recall about its effect in the hemodynamics. There is going to be a decrease in the blood pressure, the cardiac output, the patient's lung function. There is going to be tachypnea, respiratory distress, oxygen levels will tank, and of course, we are going to expect the patient to have more complications to happen in the alveoli, especially if this is not treated early on. Remember? So if there's a chance for them to get treated as early as possible, then they can go into that proliferative phase, right? If the repair is successful, then they're not going to go into the fibrotic phase. However, if the repair process is not effective, then chances are they're going to lead into the fibrotic phase, wherein the person will end up with much more permanent damage, fibrotic lungs. They're going to require more of the oxygen for long-term use, and repeated inflammation can occur into these patients. Now, remember, guys, about the modality during the acute phase. We're going to make sure that we're treating their oxygen levels. If there's hypoxemia, we have to supplement that with the use of the oxygen. And most often, they're going to end up being on the ventilator. So again, think about the setting here. Look into the setting, regulate the setting, make sure that we are looking into the patient's responses, okay? Remember that PEEP, you have to keep an eye on that one, because that can also cause complication. Like I've said, it can lead into compression of the vena cava. There will be a reduction in the preload. It will decrease the blood return to the heart. It can also decrease the cardiac output, which will eventually cause the blood pressure to go down. And so we want to make sure that the PEEP is regulated according to the patient's need. We're not going to overdo it, okay? And so when the patient has a accompanying sepsis or infection, we really need to treat it in order that we are going to eradicate the infecting organism in order to lessen the inflammatory process. Because again, the process is involving neutrophils, right? That is the main actor of this disorder. The release of the neutrophils. It will cause the inflammation. Don't forget about this. I'm not going to repeat all those all over again. So I hope that you were um, able to understand the mechanism, the pathogenesis, and also the care of our patient clearer this time. So I hope that you were able to capture all those. And that's it for today. I will talk to you tomorrow again. Same time at 9 Eastern time. Make sure that you invite your friends. For those who are able to attend, make sure that you tell them. And we'll tackle the respiratory failure tomorrow. And I'll see you again.